Hey folks, Dan Griffin here. Let's hop right into anatomy of the heart. We'll start off with this high yield image because many patients suffer myocardial infarctions. Test question writers can easily integrate ECG findings to see if you know how to localize the infarct to a specific artery. Now, the coronary arteries originate from the aortic root just above the aortic valve cusp. And due to this, the aortic valve leaflets actually block the openings of the coronary arteries during systole. And this is why most of the blood actually enters the coronary arteries during diastole. Now, the right coronary artery comes off the right side of the aorta, and the left main coronary artery arises from the left side. Now, the left main passes between the pulmonary trunk as well as the left atrial appendage, and then it divides into the left circumflex as well as the left anterior descending artery. The left anterior descending artery descends anteriorly within the anterior interventricular groove toward the apex of the heart. Now, on its course, the LAD gives off branches that supply the anterior two-thirds of the interventricular septum, as well as the anterior lateral papillary muscle and the anterior surface of the left ventricle. And a good way to remember this is just to understand what is directly up under the left anterior descending artery, and that is the interventricular septum. And that should make a lot of sense because the interventricular groove of the pericardium sits directly above the interventricular septum of the myocardium. This is particularly high yield because an infarct of the interventricular septum will increase your risk for rupture and the creation of a VSD because the infarcted muscle will leave non-viable myocardium, which is prone to rupture when the macrophages start removing the necrotic cells. Now, what about the left circumflex artery? Why do you think it's called the circumflex? Well, this is because it winds around to supply the posterior wall of the left ventricle. Also off the left circumflex, there's a large branch called the left obtuse marginal artery, which aids the LAD in supplying the left ventricle. And which portion of the left ventricle do you think it supplies? There you go, the lateral portion of the left ventricle. Another important point to note is that the left circumflex also supplies the anterior lateral papillary muscle, as does the LAD. So this means that the anterior lateral papillary muscle has a dual blood supply from the LAD as well as from the left circumflex. So with that dual blood supply, do you think it's more or less prone to rupture? There you go. It's going to be less prone to rupture. And remember that the posterior medial papillary muscle is more prone to rupture because of the single blood supply. Now, what about the right coronary artery? Well, as we said earlier, it arises from the right side of the aorta, and it delivers blood to the right ventricle via the acute marginal branches. And in 85% of the population, the right coronary artery also gives rise to the posterior descending artery. Now, in 8% of the population, the posterior descending artery will arise from the left circumflex, and in the remaining 7%, it will be a contribution from the left circumflex as well as the right coronary. I wouldn't worry so much about memorizing these percentages. Just remember that for a large part of the population, the posterior descending artery comes off the right coronary artery. After that, you should be good. So, if the left anterior descending artery supplies the anterior two-thirds of the interventricular septum, which artery do you think supplies the remaining posterior one-third of the interventricular septum? There you go. That's going to be the posterior descending artery, which remember, the majority of the time comes off the right coronary artery. Due to it supplying the posterior interventricular septum, it is even sometimes called the posterior interventricular artery. Now, a few other important points to remember about the posterior descending artery. It's going to descend down the posterior side of the heart toward the apex. And it also supplies the posterior medial papillary muscle. And it is the sole supply for this papillary muscle, which makes it more prone to rupture. Alright, now that we know what each coronary artery supplies, let's take a look at our ECG. Here we're going to be looking at different locations on the ECG and trying to determine which artery supplies that area. So to start out, let's look at lead 1 and AVL. Now these look at the lateral side of the heart, and if you see ST elevations here, you should be thinking the left circumflex artery. Next up, we have leads 2, 3, and AVF, and these look at the posterior inferior side of the heart, which is predominantly supplied by the right coronary artery. Next up, we have leads V1 through V4, and these are the interventricular septum, which again is predominantly supplied by the left anterior descending artery. And last but not least here, we have leads V5 and V6, and these look at the lateral side of the left ventricle, which is predominantly supplied by the LAD as well as the left circumflex. Now this information will be covered again in the CV pathology section, so be on the lookout for it and see how much you can remember. Now let's take a look at the SA and the AV nodes. The SA node is commonly supplied by the right coronary artery via the SA nodal artery. And the AV node is commonly supplied by the posterior descending artery, which again branches off the right coronary artery about 85% of the time, the left circumflex about 8% of the time, and is codominant from the left circumflex and the right coronary about 7% of the time. So knowing all that info, what if someone had an RCA infarct? What might you see? There you go. You could get significant bradycardia or heart block due to SA or AV nodal dysfunction. Now, I know we already covered it once, but this is incredibly high yield, so I want to cover it one more time right here. The posterior medial papillary muscle is only supplied by one artery, and that's the posterior descending artery. Since it is only supplied by one artery, it makes it more prone to rupture in the setting of a myocardial infarction. And if you happen to rupture the posterior medial papillary muscle, how do you think this would present? New acute onset mitral regurgitation and inflorid heart failure. Now the next high yield fact has to do with the posterior part of the heart as well as an important nerve, and a question might go something like this. You have a 54-year-old female with a history of rheumatic heart disease who's being followed by a cardiologist for mitral stenosis. A transesophageal echo was recently performed due to hoarseness and mild dysphagia. What do you think the TEE results would show? Now the point of this question is to help you understand the relationship between the left atrium and the esophagus, as well as the branch of the vagus nerve, which is a left recurrent laryngeal nerve. Now, the left recurrent laryngeal nerve loops under the ligamentum arteriosum on its way back up toward the head. And this woman has chronically elevated pressures within her left atrium due to her mitral stenosis. This is going to lead to an increase in the left atrial size, and this is what you would see on the TEE. Now, this huge left atrium is going to compress the esophagus, leading to dysphagia, as well as it can press up against the left recurrent laryngeal nerve, and this will cause hoarseness. And what exactly does the left recurrent laryngeal nerve innervate again? There you go, the intrinsic muscles of the larynx. Now next up, we have this important image to look at the different layers of the heart. Our outermost layer here is the pericardium. Now it's composed of two layers, a fibrous outer layer and an inner serous layer. And you can see these here. Now the serous pericardium also has two layers, the parietal or body wall layer and the visceral or organ layer. Now the visceral layer of the serous pericardium is also referred to as the epicardium, and this is what directly overlies the myocardium. The space between the parietal and visceral layers of the pericardium is called the pericardial cavity, and it contains a small amount of ultrafiltrate to act as a lubricant between the two layers to allow motion of the ventricular chambers. Now, the pericardium itself is innervated by the phrenic nerve, and in this situation, the pain would actually be referred to the shoulder. Alright, now let's try our hand at a USMLE style question. A 67-year-old man presents to the emergency department with diaphoresis and crushing chest pain that radiates down his left arm. An ECG is obtained, and his troponin I level is noted to be high. He is taken to the cardiac catheterization unit where he is definitively diagnosed. Assuming that this man's coronary vasculature is right dominant, which of the following areas would be most likely spared after this event? Would it be A, the interventricular septum? Would it be B, the atrioventricular node? Would it be C, the posterior interventricular septum? Would it be D, the right ventricle? Or would it be E, the sinoatrial node? So let's take a look at our ECG, and what do we see? Well, we see ST elevations in leads 2, 3, and AVF, and this is consistent with an inferior MI, which is supplied by the right coronary artery. Now the question states that the patient has a right dominant coronary vasculature, so we just need to remember what the right coronary artery supplies. And looking at our image here, we see that the right coronary artery gives rise to the right acute marginal artery, and in people who are right dominant, it gives rise to the posterior descending artery. So with all that, we know that the right acute marginal artery supplies the right ventricle. So in this case, D is incorrect. And the posterior descending artery supplies the AV node and the posterior part of the interventricular septum. So B and C are incorrect. Now we're just left with A and E. And if you remember back, the right coronary artery supplies the SA node via the SA nodal artery. So E is incorrect. So that leaves us with A, which is the correct answer here. The anterior interventricular septum is the only area that's listed that is spared by this infarct. And do you remember what supplies this area again? Great, the LAD. Alright, well that's going to wrap up anatomy of the heart. See you in the next video.